Thanks for tuning in tonight. Just going to talk about some common equine ocular diseases. Originally, I had this with the thought of gearing this just to thoroughbreds, but really all horses should have two eyes, and we all hope that they're both functional so that we can have a safe and athletic animals. So this really is something that is useful for all breeds and all disciplines. Alrighty. So it would be a little slow on my advancement. So Charmaine gave a great introduction. I am lucky enough to have my husband that's a specialist in veterinary ophthalmology that has also trained me and has encouraged me to enjoy working on eyes, and it has worked. So moving on to the presentation, what we're going to talk about is common conditions that I see and their management of those conditions, implications in the breeding and racing thoroughbred. But like I said, this is also quite useful for all disciplines, all breeds. Probably the first thing first is it an emergency? It's not always straightforward with the eye, such as that painful colic that's down on the ground rolling. You know it's an emergency. They are telling you very explicitly that it is. The degree of ocular discomfort in the horse does not always correlate with the severity of disease, especially this is especially true in the foal, which is quite important this time of year for us all. Getting close to the horse is imperative, and getting the horse in a controlled environment is very important to give you the best chance of deciding what's going on and how important it is that you get your vet out or the veterinarian is able to make a decision on the eye. From a distance, looking at this particular eye, we can see that it could, the pain could be explained by some minor insult, like a bit of debris in the eye, or it could just be easily as serious as a full thickness laceration to the cornea, which is an emergency that needs to be attended to prevent permanent loss of vision and or the globe. I'm going to talk about some of these signs that will tip you off that you're dealing with an emergency situation that needs immediate attention, and getting a close look at the eye is essential. So first I take in the horse from afar and I observe it in its environment, how it's responding to its handler, the objects moving around it. Is the eye held open or closed? Is there tearing or other discharge? Signs of rubbing, the inside of the knee on the side that the eye is a concern is a good telltale sign. You'll see some rub marks on the inside of the knee. That's their favorite little place to rub. What about the position of the globe and the position of the eyelids? Let's see if this works here. There we are. That red arrow there indicates we've got a dropped lid. It's a pretty swollen eye with mild inflammation around the eye on the mare on the left there. Now, the mare on the right here, oops, that did not quite work. There we are. You see the two red arrows showing the mildly dropped eyelid, which would be a bit hard to pick from afar, and that mild grayness or edema in the cornea. The difference between these two cases is pretty drastic. The mare on the left just has a minor ulcer that is infected and some inflammation and pain associated, and she'll be quickly cured of this if she's attended to quickly. The mare on the right had a onset of severe uveitis or inflammation inside the globe that eventually led to glaucoma and blindness of the left eye. And that mare is actually blind in that eye, unfortunately. Moving on to looking at the eye from different perspectives. I guess it's true in life and it's true in looking at eyes. Look at things from different perspectives to get the full story. So looking at the eyelid margins, looking at the third eyelid that will be down in the inside corner of the eye and may be raised up. And then look at the globe itself and the shape of it. Assessing the cornea with a light in a darkened environment will give you the best chance of identifying something abnormal. And looking at changes from a clear cornea, such as a red color, white, cream color, or a change in the contour, as you can see in the image on the left hand of the screen. Um, and I also take a lot of pictures on my phone. The lenses of many phones today are surprisingly good. It not only helps document findings on my side as a veterinarian, but it makes it easier for me to discuss this with colleagues or for clients to discuss changes they're seeing in an eye with me. After experimenting with a number of different techniques and expensive cameras, really, if I use my iPhone camera, I turn the flash on, I increase the zoom to about 1/3, and then I make sure my focal point is the center of the eye and I'm in a dark environment, I can get a really useful image that can tell a lot. Um, Oftentimes this will help us decide what needs to be seen right away and what might need to be seen on a non-emergent basis. It's not perfect, but it's a tool that we can use. The Corse's eye protrudes easily, protrudes from the eye naturally as a prey animal. It's positioned in that way for them to see approaching danger, but that also means that it's in a vulnerable position and easily damaged. The cornea is thin, with even a thinner protective epithelial covering, preventing it from the environment, and it needs to be clear to allow normal vision. Many ocular diseases can affect corneal clarity, and this structure, it should be transparent to allow a clear view with the underlying brown iris, as you can see in this image. All quite normal, but if you look closely, there's a slight circular hazy region, which is a superficial ulcer in this eye. So why is ocular health important? I probably don't have to convince many of you that it's important. It just kind of makes sense to us. But for racing horses or horses intended to race in Australia, AR 80 states that horses are ineligible to race if they're totally blind in one eye, or if a horse has partially impaired vision or is ineligible to race unless the stewards are satisfied based on a specialist veterinary evidence that the impairment does not constitute as a danger to the horse or other participants in the race, official trial or jump outs. So there's definitely reason to attend to your eyes and make sure that your young stock and your racing stock are going to go on and be successful on the track. So we'll start with equine ulcerative keratitis. It's one of the most common issues a veterinarian is called to attend to an eye. The location is on the side of the head, which we know means that it's quite exposed. And we know that environmental conditions increase it. So we do see more ulcers when there's an increase in insect infestations and environmental dust as well. So Australia is a great place to injure your eye at times, but really it can happen anywhere in the world if you're a horse. A superficial corneal ulcer, this is the most common thing that you see wrong with the eye. Typically a superficial ulcer responds well to treatment with broad spectrum topical antimicrobials, and most will resolve within 5 to 7 days without complication. We have to keep in mind that the equine cornea is only about 800 microns thickness, less than 1 millimeter in thickness. So determining the extent of damage is hard without magnification that a veterinarian uses when examining the eye. Don't take injury to this region lightly. Because of how thin it is, and it doesn't have direct blood supply in a normal cornea, infection in the cornea can be unforgiving and advance quickly. So simple can become quite complicated, as in this eye that has a severely infected ulcer. So moving on to deep stromal ulcers, or ulcers that are beyond just the superficial layer of the cornea. These three eyes here have varying degrees of depth and malacia, or what we call melting. Infected ulcers can melt if the wrong bacteria or fungus infect the ulcer, and this can happen very quickly, resulting in rupture of the eye within 24 hours. So it needs to be addressed quickly. When these situations become severe and we're worried about the integrity of the globe, we often operate. Conjunctival grafts is the go-to procedure to save these severely infected and deep ulcers. Though we're increasingly moving towards clear cornea approaches such as corneal conjunctival transposition and amnion placement. To achieve good results with these surgeries, an operating suite with an appropriate head position of the horse and adequate magnification are needed to achieve good results. And in such situations, success rate after grafting is high. There will be some degree of corneal opacity or scarring in the area of the graft, but if caught quickly and the area of disease is minimal, this is rarely career limiting. You'll see that the circular region that the graft is covering there, the graft will be left in place with a normal blood supply. And then when the entire area is healed, that long stem pedicle will be trimmed. So then you're left with just a circular opacity in the eye that the horse can see around in this particular case. So moving on to fungal keratitis. This is when a corneal ulcer becomes infected with a fungus instead of just a bacteria, which is more common. Fungal keratitis or ulcers that become infected with fungus are often occur because of an opportunistic infection where there's an injury to the cornea and then with concurrent antibiotic or steroid administration, the fungus comes in and takes residence. We also see a higher incidence of this in wet, humid climates, but it doesn't mean that if you live in a dry climate, you won't see it. It can still occur. It's difficult to treat, and we often recognize the fungus later in the disease process. It is slow to start, but it is persistent, and it's very slow to kill with antifungals. So identification of this early is important. And oftentimes will have to be managed surgically because of the difficulty in eliminating the fungus. The prognosis ranges somewhere between 50 to 90%, and this is highly dependent on the time to referral or treatment of this infection. Quick identification will always result in improved prognosis, almost always. Often surgical removal of the fungus or a keratectomy or cutting out the infected region of the cornea, and then grafting is the best way to resolve these cases quickly. So for the deeper, more infected melting or malacic ulcers, or the very fractious animals, so the untrained, young, unhandled horse, or just a difficult horse to deal with, we place subpuberal lavage systems or catheters, or you may have heard them called treatment tubes. These are essential in these cases. They are typically placed under standing sedation with local nerve blocks, but we have to be quite careful to have control of the horse with a trusted handler, or eyelid laceration or complete globe rupture can occur. So in some situations, a short general anesthetic is imperative for placement of these. Lavage lines avoid the necessity of the individual giving treatment to pry open the eyes each time and put pressure on the painful eye or eyelids. It reduces the horse's ability to get away from you when you're giving medications, and it's less labor intensive. It is important to monitor the tubes closely. They can be damaged, they can be dislodged, and it's important to give only one medication at a time and give time in between medications so each medication has an opportunity to work. Reflux anterior uveitis, you may have heard of. This can happen when there's severe disease on the surface of the cornea. The interior portion of the eye reacts to it. The inflammation within the globe causes the pupil to constrict, and fibrin or hypopyon or cellular debris develops inside the eye. This needs to be treated with topical mydriatic drugs such as atropine, along with systemic nonsteroidal anti-inflammatories. Once the eyelid or the pupil is dilated or mydriasis, this assists with pain, not only as well as the inflammation within the eye. If this is not addressed concurrently with the surface disease, a more robust uveitis and a more permanent uveitis, resulting in disruption of the fluid flow in the eye, long-term in the eye. So it should always be addressed. Anytime a horse is on anti-inflammatories, systemically long-term, as well as atropine, we always have to monitor the horse's GI tract, because we can see mild signs of colic in some horses when they're administered these drugs. Indolent ulcers, this is another form of a wound in the cornea, but this is when the not overtly infected ulcer fails to heal with routine topical medications. They're not very common in the horse, but we do see them in the older horse, or the horse that is immune compromised, such as a horse that has Cushing's disease that's not well controlled. And it's inhibiting this horse to heal its eye normally. These often require procedures such as ulcer debridement or surgical procedures as a keratectomy or diamond burr keratectomy to resolve. Right, so that is wrapping up ulcerative keratitis in a nutshell, and some of the diagnostic techniques that I find helpful. If addressed quickly, the globe can be saved and long-term scarring can be minimized in the horse. So moving on to some immune-mediated keratitis. So IMMK, or immune-mediated keratitis, is an increasingly recognized diagnosis in the horse. It's typically in one eye, not both, but it can be in both. It typically does not cause an ulcer, and it is not very commonly painful. It presents with corneal edema, blood vessels developing in the cornea with cellular infiltration within the cornea, or white areas in the cornea. The anterior chamber, or the front portion of the globe, is often quiet with no signs of uveitis or inflammation. It is important to rule out other causes of keratitis first before reaching this diagnosis. It can spontaneously resolve, further making the diagnosis difficult, and response to treatment can be variable. It can reoccur as well once the horse appears to respond to treatment once. It can go into remission and reoccur. The treatment involves topical steroids, cyclosporin topically, and if clinical signs resolve on cyclosporin, we can consider implants such as cyclosporin implants. Rarely do they require surgical keratectomies. Eosinophilic keratitis, again, the body's immune system acting inappropriately here. We don't know the direct cause of it at this point in time. And we know it has behaved differently in different regions of the world. So in the US, there's a fair amount of literature describing it differently to the fair amount of literature that's describing it in the UK. And there's still very little literature of it in Australia. We suspect that it has a parasite component, but we're not for sure. Some of these horses have high parasite burdens when fecal exams are done. We see it more often in middle-aged horses, and in the Northern Hemisphere, we have determined that we see it more frequently in the spring and the summer, but we don't know for sure in the Southern Hemisphere. It's often found in both eyes. And the lesions can be quite nonspecific at first, just an edema in the cornea or neovascularization or blood vessels coming into the cornea. It can turn into an ulcer eventually. Oftentimes we see the lesions underneath the third eyelid. And we have to do cytology or take a sample of the region to make the diagnosis, ruling out other forms of immune-mediated keratitis or neoplasia or cancer, or corneal fibrosis. So that was a very brief overview of common keratopathies. Next, we'll just touch on a few conditions that I encounter in my practice currently. So squamous cell carcinoma, it is the most common tumor of the equine ocular surface and surrounding structures. It's most frequently seen on light pigmented regions, such as the third eyelid margin or around the eyelid margins. It's not only the most common tumor of the equine eye and surrounding structures, but it's the second most common tumor in the horse overall. We see increased prevalence of squamous cell carcinoma with decreased geographic latitude, increased altitude, and increased mean annual solar radiation exposure. And we also know that there's a genetic predisposition in draft breeds. So in Australia, we definitely see this. Treatment is surgical excision plus or minus adjunctive therapy such as cryotherapy or chemotherapy. The margins around the eye can be difficult to achieve, but when possible, we want to get good, clean margins around the mass. Reoccurrence rates vary somewhere between 25 to 67%, but we know that this is lower when we have good surgical margins and when we use an adjunctive therapy with surgery. Sarcoids are tumors that can occur anywhere on the horse's body, but commonly occur around the eye, affecting the eyelid function. So you can see this large firm swelling in this mare's lower eyelid is indeed a sarcoid in her. Periocular or sarcoids surrounding the eye. The treatment is similar to sarcoid or squamous cell carcinoma, with the goal to be being aggressive right off the start. So I personally surgically remove or debulk depending on the location and how much of the tumor I can take by preserving the structure of the eyelid. And then I use adjunctive therapy to assist in avoiding reoccurrence. When reoccurrence happens with sarcoids, often it will happen more aggressively and with a vengeance at a faster speed. And we know when we have incomplete excision of these, they do happen. The difficulty around the eye versus other areas that develop in the body that develop sarcoids is that to preserve the globe or the eye, we need to preserve eyelid function. And that is not always possible. If they're very large and extensive, then removal of the tumor in the eye sometimes is indicated. Hydradenitis or summer sores is something that we see during the hot and humid summer months when the main vector house and stable flies are the most severe. These lesions can develop in other areas of the body and that can help with the diagnosis of this. So such as the prepuce or penis or any area of wounds. So if there's a wound on the leg, this will develop there as well oftentimes. In and around the eye, we see it in the medial canthus, right by the third eyelid, sometimes also involving the third eyelid, and where the tear ducts come in. The lesions appear like mineral granules or sulfur appearance. And it's this hypersensitivity to the organism is why it becomes so red and inflamed, resulting in severe pruritus or itchiness in that region, and can result in hair loss because of excessive rubbing or itching. Occasionally we see secondary ocular disease such as ulceration or inflammation in the eye. And you can imagine that occurs easily if the horse is aggressively itching their eye. It does look very similar to squamous cell carcinoma, so we need to make sure that we don't miss that diagnosis, that being much more detrimental to the horse long-term than summer sores. So treatment, regular standard deworming is your first line of defense. Cleaning the area carefully, if possible, with dilute iodine and saline. Plus or minus exploring and debulking surgically by your veterinarian may need to be done in severe cases. Systemic anti-inflammatories to help control the body's response to killing off of these organisms and help control the eyelid inflammation with the dying larvae. Environmental strategies are very important and the best way to prevent this. So controlling insect infestations and protecting the eyes from insect infestations. Because the area is irritated, the horse will be apt to rub, and so protection of the eye during this time is important. So trauma or blunt trauma to the eye, like we said, is very possible, and we know how aggressively a horse can throw their head and the force that they put behind it. It can mean many things around the eye and in the eye. It can be lid trauma, corneal ulceration, intraocular bleeding or hyphema, lens luxation because of such force, optic nerve damage, orbital fractures or the bone encasing the eye fractures and damages the eye. Assessing the extent of trauma can be difficult at initial presentation. And the eye can be the most dramatic thing you see, and it can be the tip of the iceberg. This, of course, could also sustain severe trauma to the brain, sinus cavities, or other important structures. Severely swollen eyelids are something we need to attend to carefully because if it inhibits the ability for the eyelids to close fully, the cornea will dry out and further ulceration and trauma to the cornea will occur. So always attend to trauma in the head region quickly. Eyelid lacerations, they are pretty dramatic looking, but they are the laceration that you need to attend to quickly because we need to reconstruct these eyelids to prevent any further trauma to the eye and to allow the eyelids to protect the eye going forward. With prompt surgical intervention, you have a great outcome because there's a beautiful blood supply to the eyelid. But if left gone too long, you'll have desiccation of the eyelid and reconstruction may not be possible if left gone too long. And then protect your efforts. So they are their own worst enemy. When their eye hurts, they're much like a child. They won't leave it alone. There's multiple options depending on how aggressive the horse is trying to traumatize their eye. There's multiple options out there. The clear visor obviously lets you look at the eye without taking it off. And the black cap not only inhibits vision more, but it inhibits you from seeing it, but it is an easy to use system as well. Uveitis in the horse, this is moving on into the inside of the eye. This is inflammation inside the eye, and the signs are many and varied depending on the severity. Typical signs include squinting, conjunctival hyperemia, or that red eye, or the white of the eye looks red, constricted pupil, debris within the eye, so fibrin, hypopyon in the eye. To simplify how we need to think about uveitis in the eye, I think about it as a joint. If I don't identify the cause of inflammation within the joint, address it, prevent ongoing inflammation, and prevent the nidus, and provide enough anti-inflammatory therapeutics, the joint will likely go on and develop irreversible damage and be chronically painful and have decreased function. And the same thing happens within the globe. Identification early is key. So there's many different causes. Systemic inflammatory diseases can cause inflammation. So we can see it in our severely ill newborn foals. We can see it with horses with severe colitis. Some other causes, such as Lyme disease or other tick-borne diseases can cause it, or trauma that's not addressed and continues on, and the uveitis continues to potentiate itself, are all reasons. So the key is to identify quickly and to manage it quickly. Glaucoma, or high pressure inside the eye, in the horse, it is typically caused by persistent or severe uncontrolled uveitis. The slow onset can make it difficult to diagnose. The classic clinical signs are corneal edema and a dilated pupil. If the pressure continues to rise and is not controlled, then it will result in damage to the retina and cause permanent blindness and discomfort. And horses do not respond to treatment of glaucoma as readily as other species. So if there is a concern that it has developed, accurate pressure readings are needed. Oops, sorry, a little malfunction here. There we are. Cataracts are opacity in the lens, and these can be congenital or inherited or secondary to uveitis or trauma to the globe. Some may never change, where some may progress to cause opacity through the entire lens, resulting in loss of vision. In this image here, you see small cataracts that appear as black specks against the orange background of the optic nerve. And then here you see a wide variety of cataracts that are further advanced and more easily appreciated. They can completely obstruct vision if they obtain the entire lens. Surgical removal is possible in the horse, just as it is in the human and the dog, but often the success rate is lower. And that's typically because of the reason for the cataract to form. In-depth evaluation by a specialist can inform you on how likely surgery would be successful and how likely the cataract is to continue to progress. Neonate exam. The ocular exam of the neonate is a key component of your neonate exam. So common findings that we find that are abnormal, entropion, or rolling in of the eyelids, mild or severe corneal ulcer, uveitis, or congenital cataracts. The foal's response to blink, or to an approaching object to the eye, or the menace response, is a learned response and is not developed in them immediately. So they can fail to protect their eye in dangerous situations. And then this response is even slower to form and develop and be brisk in the sick neonate foal. So careful monitoring of your foal's eyes is important, especially in the sick foal. This picture here is showing the white arrows are indicating entropion, or rolling in of the lower eyelid. So the hair portion of the lid is rubbing against the eye, which will cause an ulcer. And if it's left untreated, the foal will suffer irreparable damage to the eye. Well, that is about all I had, and I'm happy to entertain any questions that you may have.
Thanks, Jess. That was very informative. We already have one question so far. So Rachel has said, do you have to remove conjunctival grafts after they have had their effect?
So we don't actually remove the entire graft. We can trim the graft. So that long stalk that comes down and provides the blood supply to the eye, it can be removed, and that gives you the best cosmetic appearance, and it also gives you the most visual appearance, but it is not detrimental to leave it in place long term.
Okay. Thank you. We also have another question. Are horses with light-coloured eyes and skin, like cremellos, more prone to develop ocular problems? If so, what precautions can be taken to protect them from developing those problems?
Probably the most common problem that we see in the light pigmented horses, and the cremello is definitely high on the list, is squamous cell carcinoma. So protecting them with UV protection. So there are multiple fly veils out there currently, and they will tell you if they're UV protectant. And so if I see a lightly pigmented horse here in Australia, I just recommend keeping that fly veil on them during high sun exposure. Just like us light pigmented individuals are at higher risk of burning in the sun, so are they. So.
Perfect. Now we have another one here. Regarding treatment for uveitis, where you have concerns of corneal disease, I've always been overly cautious of using topical steroids. Other than ensuring there is no fluorescent uptake and primary corneal pathology / ulceration, is there any way you use of being 100% happy before using a topical steroid? Sorry, I might have read that a bit wrong. Unless
No,
you.
that's great. Yeah, that's a great question. So staining the eye is your first line, as you said. That's your most important step to ensure. Looking for any stromal infiltrates, so yellow appearance, so potentially where a ulcer has healed over and a stromal abscess has formed in the area. You want to look for that. If you see that has developed, steroids will help potentiate the infection and not stop it. So those are your main things. Making sure you've put yourself in a place to perform a good ocular exam. And then always, whoever's administering and monitoring and caring for this horse, being aware that we need to watch this horse carefully. We need to keep them from traumatizing their eye, because while they're on steroids, maybe they didn't have an ulcer when it was first prescribed, but it can develop. And the horse will not show pain nearly as overtly as a horse that is not on steroids. And obviously the bacterial fungal infection can progress very rapidly in the face of steroid administration.
Okay. We have a question there for the non-vets on the call. Someone has said, is there a way to diagnose between fungal and bacterial ulcers in the field?
Cytology. So for your vet to take a sample of the ulcer. So you have that severely infected and poorly responding ulcer, a cytology. So we look for bacterial elements, we look for fungal elements, and then we submit for culture. So we have that ulcer that's not responding in that standard 5 to 7 days, and it's progressing and looking more infected. That's when we move to cytology and culture and sensitivity.
Okay. Now, Jessie said, how many hours do we have to wait before intervention for entropion?
For entropion,
yeah.
you want to get that foal may have other reasons. So severe dehydration can be concurrently present with entropion. There can just be entropion because of the horse's conformation, the foal's conformation. But oftentimes, more often than not, that foal also has some other systemic disease where they're quite sick, and we see entropion. So if you see entropion, you want to get your vet out as soon as possible and address that, and to do a full clinical exam on that foal.
Perfect. Now, we've also got, someone said here, could you go back to the cataract side? How do we go about managing these?
Right, so cataracts can act in all sorts of ways. So they can be small and remain small for the horse's entire life, or they can progress. So monitoring if there's progression. If you want to pursue cataract surgery in that particular horse, addressing the cataract surgically sooner than later increases the positive prognosis. So, having it fully evaluated. If cataracts progress and advance quite dramatically, they can result in uveitis in a small percentage of horses. But oftentimes in the horse, there was a trauma to the eye, there was severe inflammation or uveitis in the eye, and then a cataract forms, and that's why we see cataracts and uveitis at the same time in the horse. So if you see cataracts, getting a full eye evaluation is what you want to do to look for any other reasons why there's a cataract, and then continue to monitor it if it progresses.
Okay, we've got here from Louise, in regards to pain relief and anti-inflammatory drugs for eyes, which do you prefer to use and why?
We don't have any solid evidence, Butte versus flunixin, right? But personally, I find an improved clinical outcome with flunixin in the acute phase. But I'm conscious that my horse may need to be on it for a long period of time, and I need to have something that is used easily for whichever owner I have. So in the short term, I typically reach for flunixin initially, but there isn't any hard evidence we should be using flunixin or Butte at this time.
Okay, and we've got two more and then we'll hand over to our next speaker. So how do you approach refractory uveitis cases or recurrent uveitis?
So step first is trying to find what was the reason for the development of uveitis. So reoccurrent uveitis, there are genetic predispositions such as in the Appaloosa. So we know that horse is going to be difficult to control, and those horses sometimes respond to cyclosporin implants that are surgically placed, and those can control some horses. Finding the cause, so tick-borne diseases can cause it, or it could have been because of severe trauma. So initial treatment tells us a lot. In response to that initial treatment tells us a lot how that horse is going to do long term. If it fails to respond to systemic anti-inflammatories and topical anti-inflammatories, we're unlikely to resolve it and prevent this horse from eventually losing vision in that eye.
Okay, then we've got two more, and so we've got this one. Caitlin has put a few questions here. So how long do you usually take to wean off atropine treatment, and how long do you treat stromal abscesses for? And she'd asked for some good pictures, so I might send you an email about that for Sinachai, I think is what we've got here. So I'll let you answer those, and then we'll go to Derek's question.
So the response to atropine is often related to the severity of inflammation within the eye. So I monitor their response to it. So in initial disease, it's important to be able to look at that eye regularly, once or twice a day, to see how well the pupil dilates. And then I wean them off. So if I can maintain them on every other day, that's great. If the rest of my ocular exam shows that inflammation in that eye is improving, then I don't see a reason to continue on with atropine. If as soon as I back off of atropine, the pupil quickly constricts, then I know it's too early. So it's really based off a clinical exam and then the varying disease process. And I might have forgotten the other part of that question.
No, you're okay. There was a few there. Let me just quickly get that one up.
Oh, stromal abscesses.
Yes.
How long do we treat stromal abscesses? Until we have resolution of the abscess. And so the abscess will eventually come to form often a scar. Sometimes it can return to a completely clear cornea. So repetitive ocular exams so that we can tell that that abscess is now resolved. But treatment can be extremely prolonged, and that's why sometimes we have to reach for surgical debridement or intrastromal injections to control these.
Okay, thank you. And finally, whilst waiting for the Colton sensitivity test, what antibiotics do you recommend?
So we want to have a broad spectrum antibiotic that leans towards the gram-positive side of things. Oftentimes triple antibiotic ointment that is, and there's multiple brands of that that are out there, are what we reach for. So broad spectrum. That is not toxic to the endothelium of the eye. So we can't just put any drug in the eye. It has to be formulated for the eye, and that means that we know that it can penetrate into the cornea, and we know that it's not irritating to the eye.